بسم الله الرحمن الرحيم. كل عام وحضراتكم بخير. قبل ما ابتدي بحب اشكر واوجه التهنئه لاستاذ الدكتور محمد عوض تاج الدين على نجاح المؤتمر. استاذ الامراض الصدريه، استاذنا ومستشار رئيس الجمهوريه ورئيس الجمعيه، وزملائي الاعزاء الاستاذ الدكتور محمد صدقي والأستاذة الدكتورة جيهان العسال. دي جلسة Intervention Pulmonology. الفيرست برزنتيشن لبروفيسور ابتسام اسلام، بروفيسور اوف بالمونولوجي اند كريتيكال كير يو اس اي، والتوبيك اللي هتكلم عليه بروفيسور ابتسام ايبس اند نافيجيشن وات يو نيد تو نو اونلاين. دكتوره ابتسام.
Hi, my name is Ebtisam Islam. I'm from Texas Tech University Health Science Center in Lubbock, Texas, and I'd like to thank the Egyptian Society of Chest Diseases and Tuberculosis for inviting me to give my talk today on EBUS and navigation and Vericite, what you need to know. I'm a pulmonary critical care physician in internal medicine, and you can reach me at my email and my Twitter if you'd like to follow me. So disclosure, I have no financial conflicts of interest. So the objectives we're going to talk about today are the two EBUS types, the EBUS guidelines, EBUS for staging, Vericite, and navigation. So there are two types of endobronchial ultrasounds. The first type is called the radial probe, okay? And so this is a 360-degree images of the airway, and you can see this is your probe here, and it just keeps spinning as you're looking in the airway. And the nice thing about the radial probe is that you can see the different layers of the airway, and so you can use it to target your tissue or your lesion that you're interested in. However, the disadvantages is that you cannot use it for sampling in real time. So once you locate your target, you have to remove the probe, go back in with your tools that you're actually going to use to sample with. The other type of endobronchial ultrasound is a convex probe, and most of my discussion will be about the convex probe today. And so this probe is actually used to acquire sampling tissue in real time. And so the way the EBUS probe works is that you have an angle view of 90 degrees. The direction of the view is 35 degrees forward, oblique. So the advantage of the EBUS probe, the convex probe, is that you can see color Doppler. As you see here, you see the SVZ and you see your 4R lymph node here, but you can also do real-time sampling. So again, here we see EBUS, our needle coming in to sample the lymph node. And so it makes it much more convenient when you're trying to figure out for smaller vessels that are less obvious than the SVC, whether that is a vessel or not. So the convex probe EBUS, this is a 7.5 megahertz convex ultrasound probe attached to a tip. And so this is placed to the adjacent area that you're interested in, the lymph node that you're interested in. And on the probe, you actually have a balloon filled with saline. And so that saline balloon makes contact with the wall, and you have your needle coming in to biopsy the lymph node of interest. So the nice thing about when you do EBUS ultrasound is that you use on your screen, you will have both bronchoscopy showing, your bronchoscope airways, and you also have your ultrasound images showing, okay? And so here's your EBUS scope. This is an image with the needle attached here and suction attached to the needle, and you can see the needle coming out from the top here. So what are some of the benefits of EBUS? Well, timing. So if a patient comes to me on a Wednesday clinic, I can have that patient ready to go by Friday to get an EBUS. The costs are much lower than, let's say, doing mediastinoscopy or surgery. You have better accuracy because you're able to stage those patients, go and look at the lymph nodes. Increased survival, again, with surgical or more invasive procedures that can be more kind of detrimental to the patient. It's also less invasive than, let's say, mediastinoscopy, and it prevents from fetal surgeries prevented because you've staged the patient, and if they have metastatic disease, you know then that you just need to do chemo or radiation. So these are some of the guidelines from CHEST 2016. And so what they recommend is that you can sample with your needle with or without suction. In my practice, I do use suction. You can use a 21 or 22 gauge needle. However, I will say that in larger lymph nodes, or if I suspect sarcoidosis or lymphoma, that I will actually use a larger needle like a 19 gauge. Now, the guidelines recommend a minimum of 3 separate needle passes per sampling in order to get enough tissue to make a diagnosis. And in this day and age, we're having more molecular analysis. So they recommend, in addition to the 3 samples that are taken, to at least 2 or 3 more in order to send those for molecular analysis. Now, you can use EBUS for suspected sarcoidosis or tuberculosis with mediastinal and or hilar adenopathy. And you can also use it for suspected lymphoma. This is an acceptable, minimally invasive diagnostic test. However, I do caution, if there's a high suspicion that this person has or patient has lymphoma and the EBUS samples come back negative, that obviously there should be pursuance of further diagnosis of the patient with lymphoma. So the convex probe EBUS diagnostic accuracy is about 91% via mediastinoscopy, which is about 78%. And the reason that it's thought it's so high is that because you have access to the posterior subcarinal nodes more accessible with EBUS than you do with mediastinoscopy. You also have greater access to mediastinal and hilar access. Now, it does rely on your needle aspiration. A mediastinal lymph node less than 1 centimeter has a sensitivity of 89% with EBUS. For EBUS staging, you want to start with your highest stage sampled first. So you want to start with your N3 node. So for example, if I have a right upper lobe nodule, I want to start on the contralateral side with my N3 node and work my way from N3 into N1. And what happens is that this prevents upstaging by contamination. Now, if by chance you started with a lower stage node, let's say an N1, and then you decide that you want to go to a higher stage node, it is recommended that you start with a new clean needle. Not just cleaning your needle is enough, but actually starting with a new needle in order to do those higher stage nodes so you don't contaminate those nodes. Rapid site on cytology does improve your fine needle aspiration techniques as well. So now I'm going to switch to VeriCyte. And so VeriCyte company, they have something called Percepta that we use in our everyday bronchoscopy kind of staging for lung cancer. And this is basically a genomic sequencing classifier. And this gives you an assessment of the risk of lung cancer for these patients. It does have a high negative predictive value of 91% when a patient is down classified to a low risk. So the example we use here is a D dimer. If a D dimer is normal, then it's unlikely the patient has a pulmonary embolus. So same thing here. If Percepta is low risk, then it's unlikely that these patients have a lung cancer. Now, the American College of Chest Physicians does recommend CT surveillance of these patients if there's something that you are following, but however, they are deemed low risk. 65% will have a positive predictive value when unclassified to high risk. So this is an example of Percepta, and so how we do it is that you take 2 brushes. So you take your first brush and you kind of rub the right main stem, and then you take the second brush and do the left main stem, and we cut off those brushes and we send them off to the company. In the meantime, we have filled out a form stating the patient's smoking history, what we consider them, whether we consider them low, intermediate, or high risk, and we send that form off with our samples. Now, if I get a diagnosis from everything that I've done on the patient procedure-wise, then I cancel the Percepta because I have an answer. I have a full diagnosis of this is whichever lung cancer. If I don't have a diagnosis, then I request that the Percepta be sent off and to be genomically sequenced. And so this is kind of an example of a report that we get back, and it's purposely blurry, so you don't see patient information. And so here we have our patient data. This is, you have low, intermediate, and high, and that's how the physician ranks the patient. And then this is the result after we have sent the data to get sequenced. And so in this specific report, the data came back that this patient is a low risk. If it was a high risk, you'd see a red mark up here indicating that the patient is high risk. And the third tool that we use when we use lung cancer, staging lung cancer patients, is navigation. So there are different types of navigation systems, Super Dimension, which I have used in the past, and the Spin Thoracic Navigation System. And basically the navigation system is to use for difficult to reach peripheral nodules. This is mainly what we use it for. And it's like, it maps a GPS of how you can get to that nodule that may be difficult. Now, the nice thing about the navigation system is that usually we have our patients get a CAT scan the morning of the procedure. And so sometimes you will actually have a patient that they got the CAT scan and whatever lesion you were looking at is now gone. And so the procedure, it saves the patient an extra procedure and we can send them off on their way. But you can also see if that lesion has grown and it helps you to map it. So this we use here at the university, we use the Veron Medical Spin Thoracic Navigation System. And so the nice thing about it is that no fluoroscopy is required. It has automatic registration and dynamic mapping via the VPAD. It tracks moving nodules with respiratory gait. So in real time, it's tracking the patient's breathing and how that nodule is moving with the patient's breathing. All the instruments have what we call tip tracked, so they can be monitored by the navigation system. And it also has a percutaneous part as well. So it enables, you can either biopsy the patient endobronchially. So here, as you see, navigated bronchoscopy, we would put this lesion in to be, to figure out how we would get there. Our scope would come here, we'd take a sample. If we cannot get to it endobronchially, sometimes you can go percutaneously. So you're actually going from outside in and taking samples that way. So what happens here is that when you have your patient, you have the VPAD placement for the patients. Those patients are sent to CAT scan. When they come back, their CAT scan is on a computer where we map, let's say here, the nodule that we're interested in. That nodule is then put as a target, and if there's multiple nodules and very difficult to reach locations, we'll map more than one target. So we'll have target 1, 2, 3, 4. And then it maps each target for you, so you know kind of how to get there, especially if it's in a very difficult location. And so that will help you with that. So what is the point of the VPADs? So these help with automatic registration and dynamic referencing throughout the procedure. They communicate with the system 20 times per second to up-to-date respiratory movement, and it recalibrates, it automatically recalibrates if the patient is moving during the procedure. So again, this is calibrating with the patient in real time, so whatever movement the nodule is making with the breathing, you see that as you're going for your samples. Now, the spin perc, this is where the tip-tracked guided percutaneous needle to access peripheral pulmonary arteries. So again, you would map your target. So let's say target 1, and instead of going endobronchially, or it's difficult to go endobronchially or just not feasible, the idea is that you would come from outside to inside to biopsy the nodule of interest. So the navigated bronchoscopy workflow with spin perc transition, so it does verify your registration accuracy. It navigates to the lesion. You can take away the endobronchial biopsies, and you can position the patient for spin perc. And so what you do is actually locate the entry site in a non-sterile area, and once you've located the entry point that you would be going from, you then localize, prep, and drape that area with OR towels. So now it has become a sterile area. And then a 19 gauge introducer needle is inserted into that area, and then you take biopsies with a 20 gauge FNA needle. So in summary, convex probe EBUS, we use it predominantly for lung cancer staging, and there's many benefits to it, including low cost, low risk, minimally invasive, can be done quickly. The VeriSight we also use as an assessment for lung cancer, and then the Vera navigation that we use for peripheral difficult to reach lesions that we're concerned for malignancy as well. Thank you.
Thank you so much for your elegant presentation, Professor Islam. If there is any question or comment, because Professor Islam is with us online, if any comment or question. Okay. Professor Jihan?
Yes. I would like to welcome Professor Ibtisam and thank you for very cooperation with us. She was very elegant, very cooperative, and insisting to cooperate with us to the last minute. So thank you again, Professor Ibtisam, and we are enjoyed your elegant presentation.
Thank you, Dr. Jihan. Thank you so much to the Egyptian Society for inviting me. I appreciate it and look forward to doing this every year, inshallah.
Now we'll proceed to the next presentation by Professor Robert George, Professor of Thoracic Surgery, University College London Hospitals, UK. The topic of Professor George is the future of thoracic surgery in COVID-19 era.
Good afternoon, chairpersons and ladies and gentlemen. First of all, I would like to thank the Egyptian Society of Chest Disease and Tuberculosis for inviting me to talk to you about the future of thoracic surgery in COVID-19 era. 3 to 4 weeks ago, this topic may not have been very relevant, as everyone, including clinicians, were thinking actually the COVID-19 era, the COVID-19 cases are decreasing dramatically. However, this has proven to be wrong, and now the numbers are rising again, and the world seems to be re-shutting down. In any pandemic, the primary responsibility of community, government, and healthcare systems to isolate the disease and to slow transmission. However, when the surge becomes overwhelming, essential resources become scarce and rare, and therefore we need to proactively relocate the resources to aim to reduce mortality and the number of cases and the life years lost for individuals and society as a whole. At the moment, there is not enough evidence to support the best practice in thoracic surgery during any pandemic, and the situation is highly dynamic on day-to-day basis. Cardiothoracic surgeons, however, will have great value, and they can manage during pandemic because they possess, I wouldn't say unique, but a highly relevant spectrum of skills. For example, in addition to the sterility and what we understand about theater management, we also understand how to manage and analyze and triage critically ill patients. We have good skills about endotracheal intubation and invasive line procedures. We also understand ventilators and hemodynamic management and management of ventilator complications. We have also skills how to insert the ECMO and how to cannulate and to manage ECMO. But as we continue to adhere to national and international guidelines, we must ensure appropriate patient management with best resource allocation, safety measures in response to COVID-19. In addition, we need to consider that surgical facility for emergency surgery would be compromised, primarily due to medical staff sickness, which we have already seen during the springtime, supply chain problems, and the relocation of theaters and aesthetic staff to ITU. Therefore, we must plan to learn new skills and practice and evolve our guidelines on how to manage patients with thoracic surgery requiring thoracic surgery who have COVID-19. Thoracic surgery has two main components, elective and non-elective. The extraordinary demands of managing patients with COVID-19 in a COVID-19 pandemic has disrupted the world's ability to care for thoracic malignancies. And this is where actually we as thoracic surgeons have taken the major hit, is the number of thoracic malignancies that we need to operate on, and also how can we allocate our resources to ensure that the best practice is maintained. Thoracic oncology decisions are further complicated by patients with lung, esophageal, or other thoracic malignancies are considered already a high-risk group because these patients usually have advanced age, emphysematous, and have heart disease. And therefore, any therapeutic procedures that can both impair lung function but also will expose clinical teams to aerolized viral load will have an impact on the outcomes. Therefore, a guide for triaging patients with thoracic malignancies as a response to the impact of COVID-19 has been evolved. Just a quick reminder of what happens during the exposure. We have a phase. It happens in two phases. The three phases, I beg your pardon. Phase 1 is when there is a pandemic outbreak and there is then a reduction and then a further reduction in number of overall cases. At the moment, we're facing the second surge of COVID-19 cases. In phase 1, when there is a few COVID-19 patients in hospital resources are still intact. That means ITU beds, ventilators, clinicians, PPEs are still available. The trajectory is not rapid, and for these patients, we have decided as a unit to restrict surgery to patients whose survivorship is likely to be compromised by surgery if delayed 3 months. So we look at this table over here. So if this patient, for example, has a 50% predominant solid tumor and in phase 1, of course, of the disease, and lung cancer or presumed lung cancer of more than 2 cm with clinical node negative, that means it's T1C and above, and node, then these patients maybe will do surgery performed on them as soon as possible because they will benefit the most. Similarly, those who have node positive lung cancer, those who are post-induction therapy cancers because we don't want to miss the window, those who have esophageal cancer T1B or greater, patients have chest wall tumor of high malignant potential. Again, these are patients that need to be operated on as soon as possible to avoid further complications. Patients who have a tumor in the esophagus or in the trachea causing obstruction, they need stenting. Or we also operate on patients who have been stage 2 start treatment, like for example EBUS, mediastinoscopy, either by diagnostic VATS or pleural dissemination. Surgery can be deferred for about 3 months in those who have ground glass appearance in less than 50% solid nodules or cancer, and also small tumors such as of less than 2 cm, those patients could be deferred. But coming to those who can alternative treatments considered, those who have endoscopic therapy for early stage esophageal cancer can have alternative treatment. Similarly, for lung cancer that can have SABR or ablation or stenting or debulking, all these, if you can avoid surgery, then we'd rather avoid surgery and go for alternative treatment consideration. In phase 2 of the disease, when there are many COVID-19 patients and the resources have started to become limited, for example, ITU beds, ventilators, clinicians, and PPE have been affected, and the COVID-19 trajectory within hospital is rapidly escalating, and I'm saying already within hospital, not in the community, then we can restrict surgery to patients who are likely to have survivorship compromised if surgery is not performed within the next few days. For example, those who have perforated cancer of esophagus, tumor-associated infection, tumor-associated with hemorrhage, and management of surgical complication. All surgical procedures typically scheduled as routine or elective can be deferred in phase 2 for another 3 months. In phase 3 of the disease, when hospital resources are predominantly routed to COVID-19 patients, as we have seen, resources are critically limited and exhausted. These patients, surgery are restricted to patients who will not survive if surgery is not performed within the next few hours, such as, again, perforated cancer of esophagus or septic patient, threatened airway, tumor-associated sepsis, or management of surgical complications, such as bleeding, which is not amenable to non-surgical management, dehiscence of airway, or anastomotic leak with sepsis. Surgery is deferred in all non-emergent operations. And again, alternative treatment should be considered in patients who can have SABR or ablation. So what do we do for patients who are undergoing thoracic surgery? we have different approaches. In the first approach is the preoperative management. These patients, we screen them 24 to 48 hours with a PCR and low-dose CT scan of the chest. We isolate them in a single room on the ward, and we do not allow any visitation, nothing at all, either preoperatively, perioperatively, or in the hospital. So for intraoperative guidelines, operating room management, we allow all the rooms should be sanitized, of course, before and after each case, and there's dedicated operating room if feasible. Not all hospitals have this option, but if your hospital can have a dedicated operating room for COVID-19 patients, then that be the best option. We use all COVID-19 precautions, signs posted on all our doors to the operating rooms and the suite to inform staff on potential risk and minimizing exposure. The exhaust air quality shall be greater than the supply air quantity. Maintain relative humidity between 40 to 70%. We use one-way system, so we separate the entry and the exit points. Minimize OR staff with minimum movement in and out of the operating room. Anesthetic monitors, computers, and ultrasound machine surface are all covered with plastic wraps, and these should always be sanitized before and after each case. And we avoid use of personal items such as laptops, bags, hand purse, mobile phones, etc. Of course, this is what we do in UCL. Other hospitals can do whatever they can, allowing their resources. Intraoperatively, we proceed with VATS in all possible cases to minimize aerolization of the viral loads or viral droplets. Intraoperatively, we use carbon dioxide insufflation, and before we come out of surgery, we desufflate the thoracic cavity before specimen is removal. We minimize instrument change for lymph nodes removal, and we continue suction using a filtration system. Post-operatively, there are 4 adjuncts that we adhere to. We use the equipment protocols, special procedure protocols, general protocols, and staffing protocols. So for equipment protocols, we use negative pressure isolation, ventilators are fitted with HEPA filters, and use immediate disposal of soiled PPE. For procedure protocols, we use the enhanced recovery system, and this is very important to increase mobilization of the patient and allow them to be discharged as soon as possible. We avoid use of physiotherapy and nebulizers as much as possible. We connect all the intercostal drains to wall suction using a viral filter. General protocols, we ban any visits during the perioperative period. We use video conference systems for all our patients, and we regularly surface to contaminate all the surfaces. So in conclusion, unfortunately, there is no single evidence to support the best practice for thoracic surgery during COVID-19 pandemic. And as I said, the situation is dynamic on day-to-day basis. Institutions, facilities, and any facility should have a local triaging mechanism that, based on their resources and their staffing. Pre- and intra- and post-operative measures must be taken seriously to minimize the spread and reduce the infection risk to staff. Thank you very much.
Thank you so much, Professor George. The next presentation by my friend and colleague, Professor Ashraf Matkour, Professor of Pulmonary Medicine at Ain Shams University, will speak to us about the new innovations in bronchoscopic treatment of COPD, targeted lung denervation and bronchial rhinoplasty.
بسم الله الرحمن الرحيم. في الأول بشكر الأستاذ الدكتور عادل خطاب على التقديم، وبشكر طبعا جمعية الصادق برئاسة الدكتور محمد عوض تاج الدين أستاذي، والدكتور محمد صدقي، وشكر خاص للدكتورة جيهان صديقة العمر يعني ودفعتي على المجهود الكتير اللي بتعمله في الجمعية وعلى تنظيم المؤتمر السنة دي والسنة اللي فاتت. هتكلم إن شاء الله النهارده على النيو انوفيشن ان bronchoscopic treatment of COPD, target lung denervation وبرونكال ريوبلاستي. I have no disclosure of interest. بالنسبة للأجندة اللي أنا هتكلم عليها، هتكلم على some facts of COPD كتمهيد للانترفنشن، الفايدة بتاعت البرونكوسكوبيك انترفنشن في COPD. بعد كده هتكلم على التارجت لانج دينرفيشن والبرونكال ريوبلاستي as regard الكونسبت والديليفرنج سيستم والتكنيك والإيفيدنس. Then I'm going to conclude up. Some facts about COPD that all of us know. طبعا COPD فيه chronic air flow limitation، في several phenotypes اللي هنركز عليه النهارده اللي هو الكرونيك برونكيتك phenotype. ان العيانين بتاع السي او بي دي دايما بيشتكي ففي بريزيستنت سيمتوماتولوجي. الفارماكولوجيكال ثيرابي رغم ان في فارماكولوجيكال ثيرابي افري داي حاجات جديده، لكن ساعات ان احنا البيشنت التريتمنت بيوصل لبلاتو وي كانوت اد مور وعاوزين اذر اوبشنز. فالاذر اوبشنز هي النون فارماكولوجيكال ثيرابي. في different approaches للنون فارماكولوجيكال ثيرابي. one of them is the bronchoscopic intervention. البرونكوسكوبيك انترفنشن في السي او بي دي باتر عن السيرجيكال انترفنشن في السي او بي دي برضه اللي هي السيرجيكال فوليوم ريدكشن في السيرجري. ان البرونكوسكوبيك انترفنشن از ماينر less invasive less side effect shorter hospital stay و higher number of patients can be served. كلنا عارفين ان خلال العشر سنين اللي فاتت كانت البرونكوسكوبيك تريتمنت في السي او بي دي مركزه على الانفيزيما بس، فكان في ديفرنت فرايتيز للمانجمنت بتاع الاندوسكوبيكلي للانفيزيما عباره عن اند برونكيال فالفز كويلز بيولوجيكال سيلنس اند ثيرمال ابليشن اير واي باي باس ستنتس. كل ده كان في اخر 10 سنين. لكن الانوفيشن دلوقتي اللي في الكرونيك برونكيتك فينوتايب هو التارجت لانج دينرفيشن والبرونكيال ريوبلاستي اللي هم الكلام اللي انا هتكلم عليه النهارده ان شاء الله. التارجت لانج دينرفيشن از كونسبت طبعا كلنا عارفين الكولينرجيك باس واي عباره عن cholinergic parasympathetic nerve innervates both the large والسمول airway and provide dominant innervation to the human lungs. الاسيتايل كولين المين باراسمباثيك نيورو ترانسميتر في الايرواي، الاكشن بتاعته ان هو بيعمل برونكيال كونستريكشن mucus hypersecretion and regulates الايرواي inflammation. الباراسمباثيك نيرف ديسربشن اور بلوكج دي فكره قديمه جدا، كانت في الخمسينات والستينات في القرن الماضي كانوا بيعملوا سيرجيكال فاجوتومي لبعض العيانين بتاعه الازمه او الاير واي ديزيز او البرونكيتك بيشنت عشان اوفركم الباراسمباثيك لود. ريسنتلي طبعا احنا كلنا بنستخدم الانتي كولينرجيك انهيلرز كفارماكولوجيكال ثيرابي. طب الفايده ان احنا نعمل باراسمباثيك نيرف ديسربشن اور بلوكج عشان نعمل برونكيال وور ريلاكسيشن برونكيال دايلاتيشن، يعني نقلل الميوكس سكريشن ونقلل البرونكيال هايبر ريسبونسفنس. فدي الفكره بتاعت التارجت لانج انرفيشن ان احنا انتربت الفيجاس نيرف سينجلينج تو اور فروم ذا لانج، فبالشكل ده ان احنا بناتنويت الباراسمباثيك تون فيحصل سموث ماسل ريلاكسيشن وديكريز الميوكس سكريشن. اولسو ان احنا بنعمل بلانتنج للبالمونري نيرف ريفلكسز فبتبلانت الهايبر ريسبونسفنس وبتقلل الاكسسربيشن اوف سي او بي دي. طبعا التارجت لانج انرفيشن بيبقى فوكست على anatomically only to the lung و to the depths of the pulmonary nerves only. ده الفيرست جنريشن بروتوتايب من التارجت لانج دينرفيشن، كان كبير وقصه يعني. دلوقتي هو حاجه ابسط من كده بكتير، عباره عن الكونسول ده هو فيه اللي بيطلع منه الليزر، وهنا في كولنت سيستم في كونتينوس كولينج سيستم، وهنا في البروب اخره فيه بالونه، البالونه دي فيها فلويد، الفلويد متوصل بالكولينج سيستم عشان لما تدي الراديو فريكونسي يحصل كولينج. هنشرحه. بتستخدم منظار كبير شويه اللي هو الفلكسبل برونكوسكوب الوركينج شانل 3.2 وركينج شانل عشان تعمل البروسيدير دي. هي الفكره كلها ان انت بتعمل ديول كولينج راديو فريكونسي كاسيتر اللي هي القسطره اللي موجوده دي، هي بتبقى ادي القسطره وهنا اهوت الكاثيتر شافت والالكترود. Radio frequency delivered through the airway and the surrounding tissue. These tissues are heated فتابليت وتدisrupt الفيجل موتور اكسونز نيرف outside البرونكاي، يعني بتدisrupt الفيجل نيرف بنبوظ الاكشن بتاعته. طب في نفس الوقت بيبقى في dual cooling method coolant continuously circulating through البالون. فايده الكولنت اللي احنا بنستخدمه عشان يعمل لي كولينج للانر سيرفيس اوف ذا اير واي، فبيبروتكت يعني الابيثيليوم او البرونكيال اير واي ما يبص من الراديو فريكونسي، وفي نفس الوقت يالاو الهيتنج يوصل للدبس للبلمونري نيرفز، فكده بحافظ ان العين الاوتر سيرفيس بتاع البرونكاي ما يحصلش فيها حاجه، والراديو فريكونسي هيتنج افكت بتاعتها توصل للبلمونري نيرفز. ده بيؤدي لبريزيستنت ديكريس في النيورونال اسيتايل كولين ريليز، ويقلل طبعا سموث ماسل ريلاكسيشن، يقلل البرونكيال سكريشن، بيقلل البرونكيال هايبر ريسبونسفنس. زي ما احنا شايفين هنا اهوت دي الاريا اللي فيها الاستيميوليتد نيرفز، الزون ده والزون ده بره الراديو فريكونسي. عشان كده لما بنيجي نشتغل البروسيدير ده بنشتغل 360 درجه، بناخد بوزيشن هنا وبعدين نلف المنظار هنا وبعدين نرجع نلف عشان نقدر نغطي الزونز بتاعت الابليشن كلها. بيشتغل الرايت والمين اير واي في 1 بروسيدير. الاوبتيمال باور لما ابتدوا الريسيرش كان 32 باور، بتابلاي 2 مينتس اونلي وكولينج 30 مينتس. بنابلاي في البروكسيمال اير واي والديستال اير واي. في البروكسيمال اير واي في 1 سايت اونلي، لكن في الديستال اير واي في سيفرال سايتس. البرونكوسكوبيك والفلوروسكوبيك فيجواليزيشن used to guide the electrode positioning through the treatment relative to the esophagus. يعني بنستخدم الفلوروسكوب زي ما شايفين هنا هو في البيكتشر ان احنا بنستخدم الفلوروسكوب عشان نقدر نجايد البروب ونشوف العلاقه بينه وما بين الاسوفيجس، وهنحطه في الاسوفيجيال بالون عشان نقدر نقيس المسافه ما بين الالكترود والاسوفيجس. هي البروسيدر عباره عن 4 ستيب بوزيشن. الاول بتبوزيشن في الاريا اوف انترست، بعد كده بتنفليت البالون، بتكونفيرم، وبتعمل بعد كده اكتيفيشن. المهم ان انت تعمل 4 روتيشن بوزيشن بير برونكس تو اشيف كومبليت سيركمفرنشال تريتمنت داير ان انت تلف المنظار داير عشان توصل للقصه دي. هنا هو دي بقى البروسيدر حصل فيه انوفيشن لما ابتدوا يشتغلوا. في الاول كان في مشكله ان حصل حاجه اسمها الجاستروباثي نتيجه ان اللي بيحصل افكت على الاسوفيجيال بلكسس اوف نيرفز بتاعت الاسوفيجس وتعمل ابليشن. فعملوا انوفيشن في البيبرز الجديده ان هو حطوا اسوفيجيال بالون ويقيسوا المسافه من الالكترود لغايه الاسوفيجيال بالون. لو قد منظارين، عرض منظارين، يبقى ده ممكن تستخدم 32 واتس. لو قد منظار ونص هتستخدم 26 واتس. لو اقل من منظار ونص يبقى مش هتدي خالص التراكيه الابليشن. وطبعا هي ممكن تقسمها لاكثر من 12 ملم اللي هي منظارين يعني، او من 9 ل 12 ملم تدي 26 واط. اقل من 9 ملم ما تديش خالص. ودي الاسوفيجيال بالون اللي موجوده، وان هو ده الالكترود، ونقيس المسافه سهله ما فيهاش مشكله. طبعا في several studies ابتدت في 2012 واخرهم في 2018 اير فلو 1 و2 و3. الاول ستاديز بالتبعيه بتبقى للفيزابيليتي والسيفتي، وكل ده كان ويل توليريتد، لكن طبعا محتاج ان انت تعمل further investigations. I'm going to address one في ديسمبر 2019 one of the studies. الستادي دي وضحت ان التارجت لانج دينرفيشن ادي الى decrease the rate of all respiratory events significantly عن الدراج ثيرابي والشام بروسيدير. وكمان ان هي قللت الفيرست ايفنت للسيفير اكسسربيشن وفيرست سيفير تو مودريت اكسسربيشن. والكونكلوجن بتاعت الاستادي ان البيشنت وذ سيمتوماتيك سي او بي دي تريتد تارجت لانج دينرفيشن طبعا مع الفارماكولوجيكال ثيرابي ادت لديكريز الريسبيراتوري ادفيرس ايفنتس انكلودينج هوسبيتاليزيشن اوف اكسسربيشن. يبقى دي اول حاجه. الحاجه الثانيه ان احنا المشكله الثانيه في السي او بي دي كرونيك برونكيتيك تايب ان currently there are no treatment options for chronic bronchitis that directly target the cell that produce الميوكس. الجوبلت سيلز اللي بتطلع سكريشن كتير، الادويه كلها عباره عن ميكوليتيك عشان تطردها، لكن المشكله الرئيسيه ان ما حدش عمل ابروتش للقصه دي. البرونكال ريوبلاستي هو بيحاول يعمل القصه دي عن طريق نون ثيرمال بالسد الكتريكال فيلد تارجت ابيثيليوم السموث ماسل والسب يوكوس جلاند زي ما انتم شايفين هنا اهوت. هنقعد نعمل ابليشن لكل ده هوت لغايه ما نوصل لغايه الكارتلج to reduce الابنورمال عشان يتارجت الميوكس producing goblet cells leaving الاكسترا سيلولر ماتريكس. reducing الميوكس producing goblet cells may lead to symptomatic relief وفيور exacerbation. يعني انت هتحط high frequency short duration non thermal electrical field عشان تعمل ابليشن للاريا دي هي، فتعمل ابليشن للجوبلت سيلز فتقلل السكريشن بتاعت الجوبلت سيلز. فالناس اللي عندهم كوبيوس اماونت اوف سكريشن هتقللها. ده عباره عن البروب. طبعا عيب البروب ان هو سنجل يوز فمش هيستخدم كذا مره، فطبعا هيبقى اكسبنسيف. البروسيدر بتبقى سنجل هاندد ما بتحتاجش ديفرنت اوبريتورز تو دو ات. زي ما انتم شايفين ان هو ده الكيس الاول. العيان عنده سكريشنز كتيره، بيحط المش اللي هو الريوكس سيستم بتاعت الريوبلاستي، وبعد كده بيابليت السيلز بتريجنريت وبتطلع الابنورمال وذ فيور ابنورمال سيلز بتطلع ليس اماونت اوف ميوكس بقدر الامكان. طبعا دي بيكتشر بيفور اند افتر تريتمنت. زي ما انتم شايفين بيفور التريتمنت في ميوكس، في سبيوتم سكريتنج ميوكس بلاجز كتيره. بعد الريوبلاست يعني تقريبا السكريشنز بقت منعدمه او قليله جدا. هنا دي البيبر دي يمكن ادرست ريسنتلي في سبتمبر 2020 يعني لسه قريب جدا. هي ببلشت على البرونكال ريوبلاستي تريتمنت فور كرونيك برونكايتس. هشير معاكم الريزلتس بتاعت الاستادي دي، مش هخش في تفاصيلها. يعني بالابلاينج البرونكال ريوبلاستي في العيانين اللي عندهم كرونيك برونكايتس لقى ان في ريدكشن في السان جورج ريسبيراتوري كويشنير ب 15 بوينتس، وانكريز ريدكشن في السي او بي دي اسسمنت تيست باي 7 بوينتس، و28% ريدكشن في الكف، و41 ريدكشن في الميوكس. هو كل طبعا جزء منه بيعتمد على الكواليتي اوف لايف بتاعت البيشنت. الحاجه الظريفه ان هم عشان الريسيرش عملوا كرايو بايوبسي قبل وبعد البروسيجر عشان يشوفوا الجوبلت سيلز بقى بالهيستوباثولوجي هل هي اتاثرت فعلا ولا لا. فلقوا ان فعلا الجوبلت سيلز بعد 120 يوم من التريتمنت في 39% ريدكشن مين ريدكشن في الفوليوم بتاعت الجوبلت سيلز، فانديكيت السكسس بتاعت التريتمنت. برضو اللي في الاستادي ان هو عملوا بصوا على الاير واي فوليوم بالهاي ريزوليوشن سي تي بيفور التريتمنت، لقوا الانكريز ان ذا اكسسبل كوانتيفايبل اير واي فوليوم افتر التريتمنت، يعني المساحه بتاعت الاريشن جوه البرونكاي زادت، فالعيان نفسه يتحسن، فالاير واي اوبستراكشن اتحسن كمان، مش بس الميوكس سكريشن هي اللي قلت. طبعا السمري اوف سيريس ادفيرس ايفنتس في الاول 30 يوم ما كانش فيه حاجه غير واحد اي اف وبعد كده سي او بي دي اكسسربيشن. البقيه السيريس ادفيرس ايفنتس خلال ال 120 يوم اللي هو 12 شهر بعد كده ما كانوش سيجنيفيكانت ونوت دايركتلي ريليتد للبروسيدر، اتسيم ان هو سيف بروسيدر. In conclusion, targeting specific airway problems as chronic bronchitis lead to improvement in the efficacy of COPD-directed treatment. Treatment are emerging in airway-dominant COPD phenotypes. Thank you very much.
Thank you, Professor Ashraf Mukhtar, for your valuable talk. And I would like to express my deepest gratitude for the organizers of that committee and that conference for inviting me to be here. Professor Adel Khattab wants to ask Professor Ashraf about.
شكرا جزيلا دكتور اشرف، موضوع جديد فعلا. انا يعني كتر خيرك، انا اول مره اسمع عنه او اشوفه. هل هم حطوا الانديكيشن بتاعه في سبيشال فينوتايب اوف سي او بي دي، وهل في ستيج معينه ولا كمان فارماكولوجيكال هو موجود بقى في اي ستيج او اي فينوتايب؟
هو حضرتك بالنسبه للسي او بي دي هو الكرونيك برونكيتك فينوتايب. العيان لازم طبعا يبقى عنده الديفينيشن بتاع الكرونيك برونكايتس، الاف اي في 1 بتاعته ما بين 35 ل 55. العيان بيجي له ريكالنت اكسسربيشن. طبعا العيان ما عندوش اي اكسكلوجن لاذر كونديشن، كل الاذر كونديشنز هي دي اللي بيستخدموا فيها سواء الريوبلاستي. ده بالنسبه للريوبلاستي. التارجت لانج دينرفيشن برضه ذا سيم، بس طبعا هي القصه في التارجت لانج ما بيعتمدوش على الديفينيشن اوف كرونيك برونكايتس، ما يهمهمش الاماونت اوف سكريشنز اللي العيان بيجيبها، لان هو الهدف اكتر ان هو يعمل ياكت على اسيتايل كولين ويعمل برونكال دايلاتيشن. فالاماونت اوف فوليبل سبيوتوم اللي بيجيبها ما بتبقاش مهمه قوي في التارجت لانج دينرفيشن، هي مهمه اكتر في الريوبلاستي. العافيه بيه تحت امرك.
Any question from the audiences? Thank you, Professor Ashraf. Going now to the